Hi, welcome to this episode. I'm your host, Arshad Khanani with CRI Associates. And it's my pleasure to have Dr. Peter Kaiser today. He's a good friend and world-round retina expert and top KOL. He's with Coli Institute, and he's a professor of ophthalmology there. And in this episode, we'll describe how new and emerging therapies for geographic atrophy secondary to AMD can fit into the treatment paradigm for optimizing GA management. Peter, it's a pleasure to have you here.
Thanks, Arshad. Thanks for having me.
Well, Peter, before we get started talking about the GA and management, in this podcast, we actually ask some fun questions at the start and at the end. So the first question always is the same for all the faculty that join us. How did you end up in Retina? What inspired you?
It's interesting. It's an interesting story. So I always thought I'd be an orthopedic surgeon all through my life. And I finally took orthopedics in medical school, and I absolutely hated it. No offense to the orthopedic surgeons out there. And at Harvard, as luck would have it, they make you do 2 weeks of ophthalmology, which I thought was people who made contact lenses at the time, my limited knowledge. And so I showed up at Mass Eye and Ear for my usual 2 weeks of ophthalmology. They said, well, the normal guy's not here. It was a cataract glaucoma guy. And I go, well, I have 2 weeks. What do you want me to do? They said, follow this other guy around for the next 2 weeks. And that other guy happened to be Don D'Amico. So I spent 2 weeks with Don D'Amico seeing the coolest surgery and cutting edge lasers that they were working on at the time at Mass Eye and Ear. And I go, this is for me. And so I've told this to Don to say that the reason I went into Retina was specifically that rotation as a Harvard med student for those 2 weeks with them. So completely changed my life.
Don is amazing, right? Very energetic, very inspiring, top surgeon, great clinician. And, we all have our mentors that really inspire us. And really, for me, it was the same thing. We had a mentor where he was super fast surgeon, 10, 15 minutes using fast technology, latest technology, and had amazing outcomes. And he was just a clinician. His name, he still practices, Leonardo Dominguez. And really seeing him in action really made me go into Retina too. So next question, Peter, tell us about your hobbies. I know you travel around the world teaching Retina, treating patients, doing trials. I know you're a big golfer. Is that your favorite hobby?
Yeah, interestingly, so all through my life, my hobby after medical school was probably playing hockey. I'm a hockey player, played it year round. But more recently, as I've gotten slower, older, and fatter, I've enjoyed golf more. And I also picked up golf after medical school. So I'd have to say golf is one of my passions. Love doing it. Heading to New Zealand in a few weeks to do a bucket list golf trip down to New Zealand. So it's one of those sports that hopefully I'll be able to play until I'm older.
I have not picked up golf yet, but I plan to in the future. And talking about travels, I know you travel a lot. What is your favorite vacation spot? I know you really liked the recent safari you went to.
Yeah, it's hard. It depends on what you're talking about. So my family loves to ski. We've had a place in Vail, Colorado, since I was a kid. My parents have, and so the whole family likes to go out to Vail to go skiing. In terms of sheer beauty, Iceland is probably one of the prettiest places in the world. It's a postcard everywhere you look. But as you said, I love South Africa. I love Australia. There's many places that we go to. And finally, I love wine country. So we love traveling to Italy and France and other wine countries for vacations.
So what's your favorite spot?
If I had to go to one place for the rest of my life, it would still be Vail, only because the memories there since the childhood, and we'd always spend Christmas out there. So those type of memories that are just imprinted in your brain.
Oh, that's true. And Vail is beautiful too. All right, let's get to the topic at hand now, Peter. You're a world expert on pathophysiology of GA, designing trials and management. So obviously, we all know that it's one of the biggest unmet need areas in retina, and it's been exciting to have 2 treatment options approved this year. So it's a big year for our patients with GA. But before we go to the treatment options, Tell us a little bit about the pathophysiology of GA and how complement system is involved and how we can target it to manage GA, because with two approvals, we also had many failures in the field targeting complement system.
Yeah, I think it's interesting. So geographic atrophy obviously is the late form of dry macular degeneration, and it's a mistake to think that a treatment is just say for geographic atrophy. It's probably, if it works to prevent geographic atrophy progression, it probably works earlier on. And that's what's interesting about all these clinical studies, is that when you look at the pathophysiology of dry macular degeneration, it's so heterogeneous. There's the theory about oxidative stress. There's the theory of inflammation. There's the theory of decreased blood supply. There's the toxic metabolite buildup theory. And these theories may not all be mutually exclusive, but at the end of the day, no matter how the sort of first hit occurs, or even the second hit occurs, we do know that inflammation is involved. And it's probably later in the pathway, but we know that the complement system is very involved. I mean, early GWAS studies showed this, that if you had abnormalities, mutations in the complement factors, the first was complement factor H, but many followed thereafter, that you had an increased risk of macular degeneration. So that's really where the idea came from, to target the complement system. And thankfully, we've had now two different products that have crossed the finish line. One blocks complement C3, and the other one blocks complement C5. And the interesting thing about both those are they are sort of the final common pathways of all three activation pathways for the complement system. The alternative, the classical, and the lectin pathways all feed through C3 and then C5. And that's probably why both these drugs work, is that they're really blocking almost all forms of complement activation, since we don't really know what activates complement.
That's a great summary. And I think complement pathway is very complicated, and you have done a lot of work in explaining and make it easy for the field. But I agree. I think it appears, and tell me if you agree or not, that we have to block the complement pathway at a very high level, and all of it, because we had lampalizumab, which was a large phase 3 program in that study, as the anti-factor D, and that didn't work. We have had other programs that have seen failure. It appears that you have to be very potent as a drug to block the complement system and essentially, stop it. What do you think?
Yeah, I agree. Potency matters, and also getting the drug to the correct place. I mean, we don't know exactly where in the retina. We need to have a complement inhibitor, but it's certainly not in the inner retina. It has to be in the outer retina, whether that's at the level of the RPE, photoreceptor, Brooks. It's hard to say, but some of these molecules that we've tested in the past, in hindsight, may not have gotten high enough levels where we needed it. And that's a learning that we now understand and can use for designing clinical trials into the future. But as you mentioned, we don't really know what about complement is the problem. If you look at some of the GWAS studies, even some of the histopathology studies of where complement is found in a patient with dry macular degeneration, basically all three pathways, factors from all three pathways are likely involved. And the interesting thing is, we think a lot of it's the alternative pathway, which is the most active, which is, as you said, the factor D inhibitor was tested in. But one of the things that turns off the alternative pathway is factor I and factor H. And so companies are looking into that. But other factor H and drugs looking at recombinant factor H are still working. And the other one that was very interesting is we've had others that look at the classical cascade. So for instance, ANX007 blocks C1q, which is one of the first steps in a classical cascade, which historically, which is why it's called classical, is activated by an antibody. So the antibody bacterial, antibody viral interaction, but it also can be activated by things like C-reactive protein and even drusen. And so because of that, C1q makes a reasonable target.
And, they reported the data recently where they didn't meet the primary endpoint, but they had prevention of vision loss. So that's very interesting. And I think as a field, obviously we need approval endpoints, and progression of GA lesions on FAF was the primary endpoint for the earlier trials. I think moving forward, we will have new biomarkers that we need to look at, especially as you said, GA is advanced form, and the hope will be that we intervene earlier at intermediate dry AMD stage so that we can prevent GA. So, Peter, tell us the bottom line efficacy and safety from the two programs that have seen the FDA approval. So, pegcetacoplan was first approved earlier in the year based on the data, 24-month data from the Derby and Oaks trial.
Yeah, so the Derby and Oaks trials were interesting. So the studies occurred during a pandemic, so there's certainly it was difficult oftentimes to get patients back. But when you look at the results, that the original primary outcome was at 1 year, 12 months, and in this, both studies were not statistically significant. Only one was, and normally when that occurs, you'd say, well, this drug has failed. This drug will not get approved. But the interesting thing is, every study is a 2-year study, and as you started to look longer and longer over time, you started to see that the prevention of GA progression, although it just barely missed it at 12 months, started to hit it at 18 months and at 24 months. So as you'd expect and hope, over sham, the treated patients with pegcetacoplan were having an increase in preventing progression, and that increase was increasing over time. In fact, the most recent Gale study, where they looked at the next 6 months after the Derby and Oaks were completed, they continued to have an improvement in the GA progression. So the reason the drug was approved was that it might have missed the 12 months, but over time, the from 0 to 6, 6 to 12, 12 to 18, there was a progressively greater delta, and that was the basis for approval for pegcetacoplan.
Excellent summary, Peter. And I think it kind of shows, right? It's a very variable disease, that it's so many factors that contribute to GA, that in similarly designed studies with similar baseline inclusion criteria, you had outcomes that were very different, one meeting primary endpoint, as you said, and other didn't. And what about safety, Peter, based on the trial? We'll come up to the real world safety, obviously, in a few minutes, but overall safety at 24 months with pegcetacoplan in Derby and Oaks.
We started to learn about these sort of weird adverse events that were seen in the phase 2 Philly studies with pegcetacoplan. Now, the good news about Philly was it was the first time we actually prevented GA progression. So that was the good news. The bad news is we were starting to see a small percentage of patients have developed choroidal neovascularization. So they didn't have it at baseline. They obviously had atrophy at baseline, but during the study, they developed choroidal neovascularization. Now, the question, of course, was this just a random event that occurred in Philly? Well, the answer when Derby and Oaks came out was no. We actually are increasing the risk of developing choroidal neovascularization with this product. Now, obviously, the patients who developed choroidal neovascularization in the studies did well from a visual acuity standpoint. They were treated with anti-VEGF and pegcetacoplan, so both treatments were instituted in those patients. But it's something you need to watch out for if you're treating these patients. I wouldn't recommend just treating the patient at each visit without checking an OCT at a minimum to ensure that the patient hasn't progressed to neovascularization. Some of the other things that were in the clinical study that were kind of odd, there were some cases of ischemic optic neuropathy, and there was also cases of interocular inflammation. Now, in the study, no retinal vasculitis or retinal occlusive vasculitis was reported, but there were patients who developed interocular inflammation.
I think, as you said, this is a new treatment for a new disease, and I think we have to look for all the safety signals. So this neovascularization, CNV, you have ischemic optic neuropathy, and then of course inflammation. And Obviously we have experience with pegcetacoplan since approval. We'll talk about that in real world data here in a minute, but tell us about the overall summary and the promising results from the Gather 1 and 2 studies with avacincaptad pegol for GA that now led to the approval and availability of avacincaptad a few weeks ago.
Avacincaptad pegol is a C5 inhibitor, so it blocks different from pegcetacoplan, which blocks at C3. They are both given as intravitreal injections. Pegcetacoplan is approved for monthly or every other month, whereas avacincaptad pegol was only tested monthly in the first year of the studies, and that's why it's approved for monthly treatment. In both Gather 1 and Gather 2, at 12 months, there was a statistically significant difference. So unlike Derby and Oaks, at the 12-month time point, both studies were positive for avacincaptad pegol.
And recently at AAO 2023 Retina Subspecialty Day, I presented the latest 2-year data from the Gather 2 study. As you recall, in the second year of Gather 2, patients who were treated with ACP 2 milligram in the first year monthly were re-randomized to receive either monthly ACP 2 milligram or every other month ACP 2 milligram. And patients who were treated with sham in the first year were continued on sham injection. And really, the objective of the year 2 was to evaluate the efficacy and safety of re-randomized population of ACP monthly and every other month or 2 years. Now, this is a different patient population because it was, as I said, this was a re-randomization after first year. So we wanted to evaluate how do patients do, whether they receive monthly or every other month. And looking at the data, ACP reduced GA growth when dosed every month and every other month versus sham. There was a significant reduction in GA growth in patients treated with every month and every other month. One other thing I did was to look at piecewise 6-month analysis, looking at patients treated monthly and every other month. And what we saw was that the early treatment effect was observed by 6 months and it increased over time through 2 years. And the other thing was to look at absolute reduction in GA growth from baseline compared to sham. And what we saw was that patients who got re-randomized to monthly group had less response in the first year compared to patients who were re-randomized to every other month, looking at absolute value of 0.31 millimeter square versus 0.41 millimeter square. But what we saw was in both groups that there was more than doubling of treatment effect with ACP 2 milligram over 2 years compared to treatment effect over 1 year. So over 2 years, the reduction was 0.81 millimeter square for ACP monthly and 1.04 millimeter square for ACP every other month. So again, over 2 years, more than doubling of the effect, showing us that continuing treatment with ACP, whether monthly or every other month, help these patients reduce the GA growth. So Peter, tell us a little bit about safety of the avacincaptad pegol in the Gather program, because what I've seen, obviously, from the Gather 2 data, that we had 0 cases of intraocular inflammation, endophthalmitis, or ischemic optic neuropathy.
Certainly, when we saw the results of Derby and Oaks, it was something: is this a class effect? Is this a drug effect? Really, what is it? And the fact that in the Gather 2 studies they weren't seen is definitely a very optimistic finding. Now, we're going to have to look for it in a larger number of patients. Certainly Gather 2 as well as Gather 1 were smaller studies in Derby and Oaks. There was, however, an increased rate of choroidal neovascularization, very similar to pegcetacoplan. But again, to me, when I talk to patients about these treatments, I specifically mention that developing wet macular degeneration is something that's very possible with both of these drugs.
No, absolutely. And I think, it's such a big unmet need that many patients are okay with that side effect because we have good treatments. And I tell them you may end up with 2 injections. And they say, as long as I can keep my vision longer, I'm willing to take that risk. Now, of course, safety is important for any new agent. And as you recall, ACP was FDA approved in August of 2023. So we are still collecting the real world experience in larger number of patients, obviously, with different baseline characteristics. Clinical trials always have inclusion exclusion criteria. But looking at the 2-year data from the Gather study, what we have noticed is that looking at treatment emergent adverse events, 2% or greater, there were two things to highlight: an increase in intraocular pressure of 13.3% in ACP compared to 0.9% in sham. And as you recall, this is a 100 microliter injection. So there will be some increase in IOP, and most of these events were transient and they resolved the same day. The other thing we have noticed with complement inhibitors, as we discussed, is increased rate of CNV. So over 2 years, that rate was 11.6% with ACP compared to 9% with sham. But interestingly, in the second year, the rate was comparable in every other month group of 4.3% and sham of 5.4%. So every other month dosing appears to have less risk of CNV. The other things we want to look at, obviously, is serious ocular events. There were no cases of retinal vasculitis, retinal artery occlusion. There was one case of culture positive endophthalmitis and one case of subluxated intraocular lens, obviously unrelated to ACP, in 2-year data from the Gather 2 study. And lastly, intraocular inflammation and ischemic optic neuropathy, like we discussed, are important to look at. Over 2 years in the Gather 2 study, there was only one case of non-serious intraocular inflammation, which was reported as trace vitreous cells. And there were no cases of ischemic optic neuropathy or retinal vasculitis in the Gather 2 study over the 2 years. Peter, to wrap up this podcast, a couple more questions about yourself. What is the career achievement that you are most proud of?
I think the achievement so far is that I've received 2 lifetime achievement awards, one from AAO, one from the American Society of Retina Specialists. And so I consider myself a young man, but receiving a lifetime achievement award from our 2 major societies, to me, is something really to be proud of.
It tells me you're doing everything right, Peter. You're only 35 years old and you've got 2 lifetime achievements, right? I think you also take pride in your fellows, the people you train on a daily basis. They have become chairs of departments. They've become KOLs that are international. So I know that work you're giving back to our field has been very impressive. And then the last one is, how do you want to be remembered when you retire?
Hopefully, I want to be remembered as a good father, a good family man, a good friend to all my peers in the retina community, and then as somebody who actually spent their lives trying to give back. As you said, I've taught a lot of residents and fellows, and they have sort of taken their own careers. So my teachings have legs of their own. But also, having been involved, as with you, with many drugs that now have changed the lives of patients, hopefully I'll be remembered for having a small part and doing something to really reduce the risk of blindness in our patients.
You have done amazing service to the patients and millions of patients around the world using science and being very data oriented. So thanks for doing that. I'll always say that you are fun. It's always fun hanging out with you. So you have a long career ahead of you. You're not retiring now, but I just tell everybody that it's always fun working with you, that it's always a pleasure having you as a friend, but also working on new clinical trials and development, and while having fun doing that. Thank you, Peter, for joining us today and for excellent discussion. And thank you to the audience for listening to this podcast.